Hello doctors, Dr. Najeeb here again. Today I am going to talk about a vessel, an artery and its related vein, that if you don't understand that artery and its variants, then during very common surgeries like hernia surgeries, inguinal hernias or femoral hernias or retropubic manipulations or retropubic operations, right? You might kill your patients. You can kill your patients. Again, I will repeat it. It's worth it. Today, I'm going to explain thoroughly an artery and its associated vein and its variants, because it's very important to understand that artery normal origin, normal course and normal distribution of blood supply. And also, you must have a very crystal clear concepts about this artery's variants and its veins variants. You know how common are their variants? In almost 50% of population. And those variants, which are accessory arteries or aberrant artery, those variants come on the way of surgical or laparoscopic work when we are managing femoral hernias or inguinal hernias, or even when there are pelvic fractures, especially anterior pubic ramus fractures, or when you are doing some pelvic surgeries like bladder surgery or any retropubic surgical procedure. If you don't know these variants, then your patient might bleed to death, right? Why it is so, I will explain in this lecture. First, I will tell you the name of this artery. This is obturator artery. Everyone knows that. Every doctor or every medical professional know there is an artery which is called obturator artery. But very few know that every year, somewhere in the world, someone loses life because surgeon was not properly aware of the variants and you can say dangers of associated with this artery, right? So today we are going to talk about normal obturator artery first, normal first, right? Its origin and its course and its branches and distribution of blood. Then I will tell you what is the difference between normal and accessory obturator artery. Then we will proceed in the lecture further and we will see what is the difference between accessory obturator artery and aberrant obturator artery. By the end of the lecture, you must be able to have a crystal clear concept about normal obturator artery, accessory obturator artery, aberrant obturator artery, and then a very dangerous killer anastomosis, right? That eventually leads, we call it corona mortis, crown of death. If surgeon is not careful about crown of death, patient will die, but crown of death will be placed most probably on the head of the surgeon, right? So let me talk about this artery. From where this artery comes, obturator artery. Start from the very beginning. What is the most common, classical, typical origin of this artery, right? Let's suppose here is aorta, very simple diagram. This is aorta and here it comes common iliac artery, common iliac artery, and then internal iliac artery, and here is also a branch which is internal iliac artery, right? And you know this is external iliac artery, and here is again external iliac artery. And as most of you are so intelligent, so you must be knowing this is inguinal ligament. And when external iliac artery crosses under the, what is this, inguinal ligament, it becomes femoral artery. In the same way here also, what is this? External iliac artery, as it crosses inguinal ligament, it becomes femoral artery. Now, in this scheme of basic scheme, that aorta is there, right? And of course common iliac, and then divide into internal iliac and external iliac, and when it crosses the inguinal ligament, it becomes femoral arteries. Out of this basic design, where is the obturator artery origin? The classical origin, right? Classical origin of, I will make it green, right, just to differentiate it. Actually, look at it, internal iliac artery, right and left, they are the main feeders to the pelvic organs. They are the main feeders to the pelvic organs, right? Now, they divide themselves into posterior branch and anterior branch, posterior branch and anterior branch. Now, this anterior branch, right, from here, one of the artery which is given out, this is obturator artery. So, obturator artery in its classical sense, in its most typical form, right, it is originating from, yes, anterior branch of the internal iliac artery, right? This is the origin. Now, I need to be I should give a lot of stress about its origin, because this origin, which is classical origin or most typical origin, or we can say most common origin, is only 70% to 80% of the population. It means almost 30% of the population, almost every third person or fourth person has origin from somewhere else. Every third or fourth person has origin of this artery from somewhere else, not from its typical place, not taking origin from internal iliac system. Rather, in every third or fourth person, this artery in its origin shows variant, right? Shows variant. And what is the variant thing? That basically artery, I will make it black because that is going to be dangerous, right? This artery might take origin from, what is this? External iliac. External iliac gives a branch which goes upward, and this branch is called inferior epigastric artery. Here is inferior epigastric artery. Sometimes in 20 to 30% of the patient, wow, it takes origin, it should go medially. It should go medially. So this is going, what is this? Inferior epigastric artery. Now, in 20 to 30% of the population, obturator artery might take origin from inferior epigastric artery, right? From inferior epigastric artery. Now, I must make it black. It is dangerous. this origin is going to be dangerous. I will explain it later. Now, if it's taking origin from its normal place and there is an extra branch coming from, what is this? Inferior epigastric artery, which is from external iliac system. What is this? External iliac arterial system. And this is internal iliac arterial system. Now, classically, typically, most commonly, it should originate from internal iliac system. But in 20 to 30% of the population, it takes origin from external iliac system. Right? External iliac system, actually what I mean, the branch of the external iliac system more commonly, that is inferior epigastric artery, and in some cases it may take origin directly from external iliac artery. Now, so it means that most common origin is from internal iliac system and less common origin is from external iliac system. But less common is really not rare. It is every third or every fourth person. Now this origin can make big problems. Now we imagine if we call its artery is normal origin. What is this? Normal origin as O. This is normal origin. Right? In this diagram, I'm showing that there are two arteries. One is taking normal origin and there is an additional supplemental branch. There is additional supplemental branch. If it is so, then we will call it obturator plus this supplemental branch is called accessory branch. Right? So we can say what is the real difference between the most we call most typical or classical normal, right? So normal is taking origin from the internal iliac artery anterior division. But if there is additional supply coming from external iliac system, more commonly from the branch of external iliac artery called inferior epigastric artery. If there is obturator arteries additionally taking over here and there are two obturator arteries, so we will say there is O plus A. This patient is O plus A. Now, this artery which is additional, this is called accessory obturator artery. So many of us have only typical obturator artery which we call normal, and many of us have typical obturator artery plus an extra or supplementary artery or additional artery in addition to the typical one, that is accessory artery. But classical one should come from internal iliac system and additional one here is coming from external iliac system branch. Of course, this is inferior epigastric, which is the branch of external iliac system. Is that clear? So it means when we say that there is a person who has accessory obturator artery, it means in this person there is typical obturator artery also plus there is additional accessory obturator artery. Now we think of another person. In that person, the origin from, what is this? Normal is not there. This origin is transferred here. What does it mean? That there is no classical, normal, typical obturator artery, right? And there is replacement artery which is taking origin from external iliac system, most commonly from inferior epigastric artery, and less commonly from other places like directly from the external iliac artery. Now, what we understand, if there is only from here, only from internal iliac system origin, this is a classical, typical, normal, and you will see later, I will explain, it is good for surgery. Less chances that we will hurt this artery. And more dangerous is if normal artery is also present and additional artery is also present as accessory obturator artery. And most dangerous condition is normal is not present but very high flow and high pressure replacement artery is present from the external iliac system, especially from inferior epigastric artery, right? These accessory artery or aberrant obturator artery is this additional, this is not additional, you can say replaced artery. Normal artery has defected from the internal iliac system, its origin has defected to the external iliac system. This artery is dangerous. Actually, you should remember, whenever obturator artery takes origin from external iliac artery, external iliac system, whenever obturator artery takes origin from external iliac system, it is going to be dangerous. We will call it cobra artery. It's going to be dangerous, especially in surgery around this area, right? Now, very rarely these accessory or aberrant arteries, they take origin from femoral artery as well. But it's better to forget the femoral artery. More common is inferior epigastric artery, less common from external iliac, least common from femoral artery. But one thing is very simple. If obturator artery is taking origin from iliac system, internal iliac system, thanks God. It's a good news for our surgeons. But if it is taking origin from external iliac system, just look for the normal artery. If normal artery is present, then this is extra artery, which should be called accessory obturator artery. Or if you look there and there is no normal artery present, then this should be called aberrant artery. Now, this accessory obturator artery, or if there is aberrant artery, replaced artery, they are dangerous. Just behind the superior ramus of the pubis, just behind and above, they make a very dangerous anastomosis, right? And that anastomosis, as I will explain later, if the surgeon is unwary, not very sharp, and not careful, and just his instruments nick this anastomotic artery, arterial circle, patient may bleed to death, right? And that is why this anastomosis is behind the, you can say, ramus of, superior ramus of pubis, and above it, around that area, this is called crown of death, corona mortis. Corona mortis. Now, let me show these arteries. Look at here. This is obturator artery, right? This is obturator artery. This is having origin only from internal iliac system. And from external iliac system, there is no additional artery. This is, look, this is internal iliac, this is external iliac, here it is common iliac, and external iliac has mainly, it continues itself, yes, where? Femoral. Under the inguinal ligament and becomes femoral artery, and becomes femoral artery. But just before it passes under the inguinal ligament from the right, and becomes femoral artery. The external iliac artery gives a branch, and this is inferior epigastric artery. Now, in this diagram, this is, you can say, right side from pelvic view, right? What we see, common iliac, internal iliac, external iliac, and what we really see that obturator artery is taking origin only from anterior division. This is posterior division of internal iliac. So only from anterior division of internal iliac. So this is the classical or typical or normal, so-called normal, right? Or some authors say, don't call it normal, just call it, it is the most common variant. Anyway, for our purpose, we will call it typical origin, right? So this is what we see. But let's talk about this diagram. Focus here. Again, your friend, what is this? Common iliac. This is external iliac, and this is going femoral, right? This artery from here is going under all these things. And this is what? Inferior epigastric artery. Now look at it. Here, obturator artery is taking origin in the typical fashion from the anterior division of internal iliac. You know internal iliac, posterior division, anterior division. It is second or third branch from the anterior division. But there is one problem, and it is going towards the obturator foramen, right? But there is one more problem here. Yes. Look at here. What is this? Another artery is originating from external iliac system, right? And here it is classically seen from inferior epigastric artery, and it is also going to the obturator foramen. Now you see there are two arteries approaching the obturator foramen from two different regions. One is from internal iliac system, other is from external iliac system. And if this is from external iliac system, then this artery and vein, right, this should be called additional. Normal is present or typical is present, so this will become additional. So when internal iliac system is giving the typical origin to the obturator artery, and in the same patient there is additional branch or additional origin of obturator artery from, what is this? And how we know this is obturator artery? Because it is headed towards the obturator foramen, and both of them can fuse or anastomose there and then exit through the foramen to the medial compartment of the leg, thigh. Now, this should be called accessory obturator artery. This should be called accessory obturator artery. Now, look at here. We don't see in this patient, we don't see any obturator artery originating from internal iliac system. It means the typical origin or classical origin is no more there, or so-called normal origin is no more there. But we can see what is going into the obturator foramen. Of course, obturator artery must be going to the obturator foramen. This is coming from external iliac system, more commonly from the inferior epigastric artery, or less commonly from external iliac directly, or least commonly from femoral artery. This should come femoral artery, right? Now, here you can see origin, which was classical origin, that origin has been displaced. It is no more here from the internal iliac system, rather it is at external iliac system. But now here it from the, what is this artery? inferior epigastric. From there, it, like a snake, it falls down, right? And when it is going downward inferiorly, right, it is moving down inferiorly to take a shortcut to reach to the obturator foramen, right? Every shortcut in life is not good. This shortcut is also not good. It's good to be good when you are coming from the classical or typical origin. But if you are coming from here, call it accessory artery or call it aberrant artery. If normal is present and also abnormal is external iliac origin is also present, we'll call it accessory. If normal is no more there and that is replaced by a branch coming from external iliac system, the branch of inferior epigastric artery. Now this artery goes downward and medially and approaches the obturator foramen, right? This is very dangerous artery. I must imagine it's something like cobra, right? We'll see why. It can kill the patient. We really don't know. Surgeon kills the patient or this artery kills the patient. Actually, that surgeon kills the patient who doesn't bother about concepts, who just passes exams by rote memory. But these variations, which can change the course of the surgery, these variations are not to be remembered. They need to be visualized, imagined, and actively sought for. Right? Now, look at it. When it is going down, where it is? Here is inguinal ligament. This is reflection of inguinal ligament, right? Which is going backward and laterally. This is lacunar ligament. And here, this is pectineal ligament. You must be knowing the other name for lacunar ligament is Gimber-knot ligament. This is Gimber-knot ligament. Now onward, I will call it lacunar ligament. And what is this? Cooper's ligament or pectineal ligament, right? Now look at this. And this is femoral canal. This is femoral canal. Now look at it. This artery is in a very dangerous area. This is positioned at a very strategic position, which is very lethal position. Why? Because, look, this is superior ramus. It is on the back of the superior ramus, above the superior ramus, very near to the lacunar ligament, very intimate relationship with the pectineal ligament. So, this is actually exactly where you expect this artery, this area. There are a lot of surgery goes there, right? What kind of surgeries are going on there in which this artery, if damaged, bleeding will occur massively. Now, this area, which is somewhere from an anastomosis of arterial anastomosis or venous anastomosis or both anastomosis might be present in a person. That person is going to be very unfortunate who has arterial anastomosis and also venous anastomosis. In which area? An area which is above and behind the pubic ramus, superior pubic ramus, very intimate with the pectineal ligament and lacunar ligament, very near to this area, and femoral canal, right? And crossing behind the inguinal ligament. So, this is actually inguinal ligament shown here, but if I show you more frontal view, I will make it like this, and this is pubic symphysis, and this is tubercle, right? You know, inguinal ligament originates from anterior superior iliac spine and going to the pubic tubercle, right? And here is your superior pubic ramus, right? Now under the inguinal ligament, here is your, what is it? lacunar ligament, and here is femoral canal, and then there is a septum, and there is vein, femoral vein, and then there is femoral artery, femoral vein, and here is femoral artery. All these structures are passing from abdomen to the thigh. But what is this? This is superior pubic ramus. This is superior pubic ramus. Now what I want to tell you that actually from inguinal ligament, these reflected fibers are making lacunar ligament, which is making the lateral wall of femoral canal, and some of these fibers, they continue, some of these fibers, they continue on the top of the, what is this? Pecten pubis, which is a rough ridge on the superior aspect of the superior pubic ramus, and this is a special thickening made of some fibers coming from the lacunar ligament or reflected part of the inguinal ligament and local thickened periosteum. And this ligament, right, this is very, very strong, and it is present on the top of superior pubic ramus. This is called pectineal ligament or Cooper's ligament. Please don't confuse it with the Cooper's ligament of breast. In human female breast, because it needs to be supported, so it has an internal bra. What I mean by internal bra, that if this is the breast, actually from epidermis, they are fibrous, what we can say, fibrous strands going inward, and they are attaching with the deep fascia. These are called suspensory ligament of breast, and they are also called Cooper's ligament. But this is also called Cooper's ligament. But remember, there is a big difference in Cooper's ligament of pectineal, which is pectineal ligament also, and there is a very big difference of pectineal or Cooper's ligament with the suspensory ligament or Cooper ligament of breast. So don't confuse it, right? Rather, I should remove it. I just wanted that you should not confuse it. Now, why I was drawing this diagram? I was trying to show that inguinal ligament, lacunar ligament, and what is this pectineal ligament, in the behind this area, if there is anastomosis, arterial anastomosis or venous anastomosis, right? I will tell you from where it comes. But if there is anastomosis, right, this anastomosis may become high blood flow anastomosis if there is accessory artery coming here, accessory obturator artery coming here, or you look here, what was this? Femoral. So what is this then? External iliac. And what is this here? Inferior epigastric. And what is this here coming? Accessory or aberrant. Now, and there are some other arteries which approach this area. I will not discuss at this moment. I will discuss later. If there is arterial or venous anastomosis in this area, right, we call it corona mortis, crown of death. Normally there is an anastomosis there, but that is very humble, meek, innocent anastomosis, very low blood flow anastomosis. But if a variant of obturator is feeding this anastomosis, like, what is this? What is this? Accessory obturator artery or aberrant obturator artery, then anastomosis which is formed here is very high flow anastomosis, right? And if this is arterial, it is not only high flow, but it is also high pressure anastomosis. And if you damage here, If you damage here while doing surgery, for example, you want to put a neck, what is this? Femoral canal. And if there's femoral hernia, you want to cut the, what is this? Lacunar ligament. I'm showing from the deep side. If you cut it from medial to lateral, you are going to be in trouble, because this variant accessory, or if this is not there, then it will be aberrant, right? This artery will be cut. As soon as you cut it, what you will see, if this is artery, there is the fountain of blood coming out, right? And then suddenly you try to catch the artery and you don't find the source. You know why you don't find the source? Because this will retract. Is artery or vein? If it is vein, then blood will be simply welling up. If it is artery, it will be spurting up with every pulse. But it is vein, corona mortis vein or artery, whatever was there, and you have disrespected it, right? Then what will happen? If you have cut it, or during any procedure here, you are trying to put for inguinal hernia, right? We try to put the mesh, right? We anchor the mesh with the pectineal ligament. I told you pectineal ligament is very, very strong, right? When anchoring the mesh with the pectineal ligament, you may apply what? A tax, T-A-C-K-S, tax or staples, or you suture this with this, but you didn't make it sure this artery is not there. And if you tack on this artery, or staple on this artery, or put a suture on this artery, only God can save the patient until you are not super surgeon. Why? Because as soon as this artery is damaged, and especially vein is damaged, vein has very fragile wall, paper thin walls, like a wet paper. What will happen? The injured vessel will immediately retract in the pelvis. Where? In the retroperitoneal fat. And for example, if we think of, we have put a cut here, unfortunately, for example, in lacunar ligament, if there is femoral hernia, and if you are not very experienced surgeon, and you are not learned well, not trained well, unfortunately, you say there is no problem. I have a femoral hernia which is strangulated and I can relieve it, no problem, I will cut it. If you cut from medial to lateral, and if there happens to be corona mortis, then what will happen? Bleeding. What will happen? So massive bleeding will occur from two sides. Number one, this artery will retract retropubically and then retroperitoneally into extraperitoneal fat, and now you cannot catch it, because your surgical procedure was basically limited to groin. An artery has gone retropubic space, and from there it has, you can say, retracted or recoiled back into pelvic cavity, right? And now it is bleeding and bleeding and bleeding, and you are unable to find the end, right? And if it is from both sides bleeding, here, for example, if you put I put it. Normally, you have to be very careful. If you are a very good surgeon, whenever you are going to put a neck or incision to the, what is this ligament? Lacunar ligament. First, you will make sure this arterial system is not there. But for an excellent surgeon will think this artery is always there until proved otherwise. Corona mortis is always there until proved otherwise, even though it's in about 50%, but or 40%, depending upon it is arterial or venous. And also depending on population. Arterial corona mortis are less common but strong bleeders. Venous corona mortis are more common but bleed gradually. Now, if for example this is cut, now if this is cut, what will happen? Of course, hernia will be relieved, but if you have cut from medial to lateral, you have not made it sure that it is there or not. How you make it sure? If you are doing femoral surgery, femoral hernia surgery, you will pass your finger and palpate behind the lacunar ligament. So by palpation, you will make it sure it is there or not, corona mortis. Or if you are doing laparoscopic surgery in this area, then you should visualize, before doing any other thing, you should visualize this area thoroughly that corona mortis is not there. There is no high flow, high pressure anastomosis in just above or behind the superior pubic ramus, which might be in intimate contact with the lacunar ligament or pectineal ligament or with the femoral canal. Right? This corona mortis, so you have, whenever you are doing retropubic surgery or inguinal hernia surgery or femoral hernia surgery, you must rule out that corona mortis is there or not. What does it mean? That in this special anatomical area, right, which is below the, behind and below the inguinal ligament, behind and below the pectineal ligament, behind lacunar ligament. In all this area, you have to make sure, if you are going to do surgery here, especially the retropubic procedures, they might be gynecological procedures, or there can be after a traumatic, you can say, fracture in this area, and you are going to do fixation of that fracture. You have to be very sure corona mortis is there or not. Right? Either visually or palpably. You must be knowing it. Right? And once you become sure it is not there, after that, still I would say, if you have to put the incision in, what is this? Lacunar ligament, don't put it medial to lateral, put it lateral to medial. Is that right? It's clear to everyone? Now you understand how important is corona mortis. And corona mortis, it's simple, innocent, humble, meek anastomosis. I will tell you later what are other branches. Anastomosis can become crown of death if it is fed by accessory obturator artery, and super dangerously if it is fed by aberrant obturator artery. If accessory is cut, it will be bleeding from external system and also internal system. If aberrant is cut, of course it is not bleeding from internal system, but from external system there will be, they say in surgery, ferocious bleeding. Right? This bleeding is so fast that sometimes you are just looking, where is the vessel? What should I do if you are not that good surgeon? Patient's cardiovascular system collapses. Mishaps happen to very good surgeons also, but they know what to do. What they will do? They immediately try to find this artery, press that area. If all that thing failed, because as I told you, artery or vein will retract, and usually it is very difficult to find. And it is not only artery has retracted, there are three reasons it is dangerous, this corona mortis. Number one, it might be high pressure, high volume anastomosis. Number two, that if you have damaged, arteries will retract into extra peritoneal area space, and it is difficult to reach there. And lastly, but not leastly, that this area is poorly visualized. What the very good surgeon will do? He will not start playing with this patient. he will simply go for laparotomy. He was operating extraperitoneally, but when he has put this cut, an artery has retracted or recoiled into extraperitoneal fat, and if he suspect, unfortunately he has cut the corona mortis, then he will go for laparotomy or open surgery, and then he will stop the bleeding, right? So it was all about origin of the artery. That come back. From here we'll go forward again. Yes, aorta, common iliac, internal iliac, external iliac. And what was this? Posterior deviant, anterior deviant. And normal branches coming from? Normal or classical branches originating from? Anterior deviant, and it is in the pelvis. Now exactly where it is, this diagram is very illustrative. Look at here. Aorta, common iliac, internal iliac, external iliac, femoral artery. Now look at it. Follow the internal iliac. This is posterior branch, this is anterior branch. From the anterior branch, you have an artery coming and going to the obturator foramen. This is what? Or obturator canal. This is basically obturator artery. Now, what is its course? Actually, after taking origin, this is the normal or classical origin. After taking origin from the anterior division of internal iliac artery, it moves forward and downward and hugging with the lateral wall of the pelvis. It's just like a lizard. You have seen lizard on the wall? This artery is moving like a lizard, right? Which is moving on the lateral pelvic wall, right? Now this lizard-like artery, lizards are not dangerous. And this normal artery is also not dangerous, right? Even though some girls are very afraid of lizard, but I've never heard that lizard has abducted any girl or done anything wrong with any girl or even some boy. So this artery, after its normal typical origin from interior division of the internal iliac artery, it moves downward and forward on the lateral wall of the pelvis, right? Exactly on the obturator fascia. Now what is obturator fascia? Let me tell you. Obturator fascia is part of the pelvic fascia. Which pelvic fascia? Parietal pelvic fascia. Let me show something interesting here. A very simple line diagram. I will make it here. Here is your beautiful abdomen, and here is your, okay, I'm going to make very simple. This is pelvic brim, and this is your pelvis. Okay, I will not draw your other beautiful things. Now, this is your pelvis, right? We just make one viscera. Which viscera you want? Okay, I just make bladder here, right? Now, anterolateral wall of abdomen, anterolateral wall of the abdomen, internally from the muscles, interior wall of the abdomen or anterolateral wall of the abdomen, as it is lined by skin outside, inside it is lined by deep fascia. There are muscles and other things, and then there is deep fascia. This deep fascia, which is, for example, here I must say the skin, then there are abdominal muscles, here is rectus abdominis, and then there are other muscles like external oblique, internal oblique, transversus abdominis, and if you go more deep, transversus abdominal muscle is lined by a wallpaper, lined by a deep fascia. That deep fascia is called fascia transversalis. That is called fascia transversalis. transversalis. Now, this fascia transversalis is deep fascia lining the anterolateral wall of abdomen. If it is going up, eventually it meets with the or blends with the diaphragmatic fascia, and if it is gone back, it blends with the iliolumbar fascia. So, if I draw a tummy, a man very big tummy, there's the belly button. I think it's not beautiful, but anyway, just bear with me. And here it is, suppose diaphragm. Now, this is pelvic area. Here is the pelvis. Now what is this? This area, deep fascia of the anterior abdominal wall, what is it? Fascia transversalis. Fascia transversalis. And when it goes upward, it blends here. What is this fascia? Diaphragmatic fascia. This is diaphragmatic fascia, and this is transversalis fascia. And here, what is it? Iliolumbar fascia. Right? It's clear? But from the pelvic brim, when this fascia comes down, okay, I will change the color. Suppose from here it is coming down. Now this fascia, which is with the pelvic wall, we call it parietal pelvic fascia. So actually, fascia transversalis, which is just behind the introlateral abdominal wall, when it goes to the pelvis, it changes its name, and its name becomes pelvic fascia, and because it is with the wall of the pelvis, we call it parietal pelvic fascia. And this parietal pelvic fascia, as it is coming down, suppose here is your very useful bladder, right? I don't know, I've made bladder or something else, but anyway. Now, when it reflects on viscera on the pelvis, then it is called visceral pelvic fascia. This is called visceral pelvic fascia, and on the walls of the pelvis and floor of the pelvis, this is called parietal pelvic fascia. This is clear? Now, I will just repeat it. Here, which fascia is lining? Transversalis fascia, anterolaterally. When it goes up, what is this? Diaphragmatic fascia. It goes back, iliolumbar fascia. But when it goes into pelvis, if it is with the walls or floor of the pelvis, this deep fascia is parietal pelvic fascia or endopelvic fascia. And when it reflects on the viscera, like on the uterus or bladder or rectum or other viscera, then it is called visceral pelvic fascia. Is it clear to everyone? So, lateral wall of the pelvis will be covered by fascia transversalis, or it will be covered by parietal pelvic fascia. It will be covered by parietal pelvic fascia. Now, look at this diagram. This is inguinal ligament, and above it there is a region of some muscles, including the fascia transversus abdominis. And this fascia here, this fascia, which is, we are standing inside the abdomen and looking at the anterior abdominal wall from its back. We are looking at the back of the anterior abdominal wall. So this color of fascia, what is this? This is fascia transversalis. This is anterolateral fascia, and it will go up and meet with the diaphragmatic fascia. But just below here, now this is pelvic area. This fascia, as it moves down, in the pelvic brim, this is called parietal pelvic fascia. Now its name, as here this fascia was named according to the muscles, right? Here muscle was transversus abdominis, so it was fascia transversalis. Here is iliacus muscle, iliac fossa here, right? So this is fascia iliaca, and it is not shown in this diagram, but here is obturator foramen, big foramen, and in that from internal side there is attachment of obturator internus muscle, and this fascia, this color, right? What is this color? Purple. Purple color. This is showing a fascia here. Especially, I will make it purple and black. This fascia, this is still which fascia? Now this parietal pelvic fascia, which is just overlying obturator externus, no, internus, obturator internus. Look at it. What is this? Obturator foramen, and this is obturator canal, and from this obturator foramen, it is having obturator membrane. From that inner side of the pelvis is originating obturator internus muscle, and over that, for example, let me come here in any diagram. Just again you can see what is this? Obturator foramen, and this is obturator canal. We'll see later, but this obturator foramen is having obturator membrane. Look at it here. This is obturator foramen, and it is covered by a membrane. Now we are looking from external aspect, right? So this membrane is what? Obturator membrane. Now obturator membrane internally on the pelvic side, it gives origin to which muscle? Obturator internus. And obturator internus is covered by endopelvic fascia or parietal pelvic fascia. That fascia there is little more thickened, and that is called, due to obturator muscle, that is called obturator fascia. So, wow. So, this fascia, this is all what, which fascia? Parietal pelvic fascia. Part of it which is overlying the iliacus is called fascia iliacus or fascia iliaca. Part of it which is covering over what? Obturator internus, this is called obturator fascia, right? Now look at it. This is what? Obturator membrane, but in this diagram we have already removed the obturator internus. Obturator internus. This is from inside. We are looking from inside. When we look from inside, this is obturator membrane internal pelvic view. Here it was obturator membrane external view. So here it is internal view. Here was attached obturator internus, right? Over that the fascia is this one, this purple, right, in this area. That is called obturator fascia. So once this artery take origin, from where it has taken origin?
Anterior division of internal iliac,
right, is as it moves like a lizard sticking with the lateral wall of the pelvic, moving forward and downward. It means anteroinferiorly with two more lizards. It means three lizards are going. These are not dangerous, they are not snakes. These three lizards are basically above this obturator artery is, what is this? Obturator nerve, and below this obturator artery, obturator vein, and these three trio neurovascular bundle, obturator nerve superiorly and most inferiorly obturator vein, and in between obturator artery. Now all three of them are moving on the obturator fascia on the lateral pelvic wall, downward and forward, and trying to reach the obturator canal so that they can exit from pelvic cavity, and they must have a great escape in medial side of the thigh. I think they have claustrophobia there in the pelvic. There are so many things there. I don't know. Only this neurovascular bundle can tell us. Anyway, let's come back. Wow. So what we have learned up to now, that this artery was the normal, right? Normal artery takes origin from anterior division of internal iliac artery, and then it moves forward and downward and little sideways on the lateral wall of the pelvis, lying on the obturator fascia, which is a specialized part of parietal pelvic fascia, right? And this is how it is arranged. If you move from outer to inner, if you move from the muscle obturator internus, let's suppose, okay, I will make it here. Suppose this is obturator internus, right?
Yes.
Here is which fascia there? There should be purple fascia. I don't have purple here. Give me purple. Okay, I will take it. Over this fascia, what is this purple? Obturator fascia, and it is a part of parietal pelvic fascia, and then here is your internal iliac artery going into anterior division and posterior division. From here, what was this artery? Obturator artery, which was moving on. What is this?
Obturator fascia.
Obturator fascia. Above it, it has
Obturator nerve.
obturator nerve, and below it has
Obturator vein.
obturator vein. And this neurovascular bundle is approaching to
Obturator canal.
obturator canal. I will come back to the obturator canal in few moments. So what's there? Like three lizards, not very dangerous, sticking or hugging with the wall. They're moving downward, forward, little sideways towards the obturator canal, right? All three of them will enter into obturator canal, and through there they will escape to the medial compartment of the thigh. Now what is obturator canal? Obturator canal is basically 2 to 3 centimeter long, and this obturator canal is made by splitting of which fascia? Obturator fascia, right? So in the obturator, what is this? This is obturator foramen. It's posterolateral part of obturator foramen,
Yes.
right? All obturator foramen, almost all obturator foramen is full of, covered by obturator membrane. Obturator membrane. But there is a gap in posterolateral part of obturator foramen, and this gap has fascia. What is this fascia? Here? Obturator fascia. Obturator fascia is covering the neuromuscular bundle near this foramen and making a canal so that protect this neurovascular bundle and direct properly at its exit point. So, what we have seen that these three lizards, right, they were basically traveling over lateral wall, right? Actually, if you imagine this is the lateral wall, these three lizards, what is this? Nerve. Below that, artery, and this is vein. They three are going like this. They are going on obturator muscle, but muscle is covered by obturator fascia. So this is muscle. Muscle has obturator fascia or part of a endopelvic parietal fascia, and over that fascia this was running, but as these triog moves towards its escape route, fascia fold itself and eventually split and make a tunnel, and that tunnel will direct it to the medial compartment of the thigh, passing through the obturator foramen, right? So this was structured laterally, and from where it is coming and where it is going, what is above it, what is below it. But what is medial to it? What is if you move more pelvically? There are two important, very important things we should mention. Number one, in males, vas deferens is going from down to crossing it, right? These three lizards are crossed by vas deferens or ductus deferens. Look at it, vas deferens. Here should be, yes. Look at here. What is this? Vas deferens, right? And it will come down and cross it on the medial side. On the medial side, right? Here I have not shown. So vas deferens is one important structure which crosses on the medial side. In female, there will be ovary on the medial side. And the other thing, or in this place there can be round ligament, and ovary is also medially. And other thing is, if you go posteriorly, as it is given from internal iliac, ureter crosses it while it is descending and moving far downward and forward towards its destination to urinary bladder. So look at here. This is the pelvis, right? I'm standing inside the pelvis, and here is lateral wall, here is lateral wall, right? From internal iliac, this side of the pelvis, from internal iliac, what this artery is coming? Obturator. Above that, obturator nerve. Below that, obturator vein. These three decently, slowly, while hugging the lateral wall, especially obturator fascia, which is overlying the obturator internus, right? They are gradually proceeding downward and forward. During their travel from back to front and down, posteriorly and medially they are crossed by ureter, and little anteriorly they are crossed by ductus deferens, right? And in female, ovary is also medially. Now another thing. These three lizards which are going on a wallpaper. What was that wallpaper? Obturator fascia. Actually, over this, there is a little bit extraperitoneal fat. And more medially you come, there is peritoneum. Which peritoneum? Parietal peritoneum. Which peritoneum? Parietal peritoneum. So, now look at it. These three, what is this? Obturator artery. What is this? Obturator nerve. What is this? Obturator vein. 3. And what is here? And more deep to it, lateral to it, obturator muscle, obturator internus. So from here, outer, obturator internus, fascia, pelvic fascia, which is obturator fascia, is specialized part of parietal pelvic fascia, and then these three lizards, right? And what is crossing here? Ductus deferens, medially. Here might be ovary if you happen to be a female, and it doesn't matter you are male or female, ureter also going here. So, and then on the medial most area, peritoneum is there. Now just imagine another way to mention these things. Here is pelvic parietal fascia or obturator fascia. This hand is peritoneum. With this are three things going. What are these three lizards? Obturator, nerve, artery and vein. Is that right? And these three are moving downward, forward, reaching to the obturator canal, and this fascia, which is lateral to these three, right? It eventually, as it moves forward, it makes a groove and then tunnel, right? And eventually, posterolateral part of the obturator foramen has a hole in the obturator membrane, right? We call it osseous because some part of it is bony, this opening, some part of this is bony and other is fibrous. So osseo-fibrous, you can say, opening through which they will exit to the where? Medial part of the thigh, right? Now, then what happened? Before we further go, before we talk about what it is doing once it reaches to the pelvis, we must ponder over, does it give any branches inside the pelvis? Right? Let's talk about it. Here, you see this artery is coming, and eventually it is coming out, right? You see, this is from the front view, obturator foramen, obturator membrane, the blue, and this is showing the outcoming what? Outcoming obturator artery, which immediately divides into interior and posterior branch. But before we discuss these things, let's go back and talk about, now we can say that this artery, obturator artery, has two areas. Number one, its initial area, it was traveling into pelvis. So this artery has intrapelvic course, and then once it crossed the obturator canal and exit into medial compartment of the thigh, then we say it has extrapelvic course. So we divided obturator artery intrapelvic. We talked also about that the moment it exits from the, listen, the moment it exits from the obturator canal forward, it has left the pelvis and come into medial compartment of the thigh, right? But before that, there was a lot of things we talked about when it was in pelvis, except its branches. We talked about its classical origin from internal iliac, artery interior branch, interior vein. We also talked about its variants, that if there is an additional branch coming from
External iliac system.
if external iliac system, what was this? Accessory. This person has two obturator arteries. Or we also talked about that origin was not at all. Artery origin was shifted from internal iliac to the external iliac system, and from there artery comes directly down to the obturator canal. And these arteries, we discussed accessory artery, obturator artery and aberrant artery. They are passing retropubically, and they may be a part of an anastomosis, which is very dangerous, and we call that anastomosis corona mortis. And we also talked about that this corona mortis might be present near areas of superior pubis. So say superior pubic ramus it can injure, or pectineus ligament when we are fixating the mesh or applying tacks or staples or sutures, you can damage that corona mortis, or lacunar ligament, it might be near the lacunar ligament, and inadvertently you might cut this while making an incision in the lacunar ligament to relieve the strangulated or incarcerated
Hernia.
femoral hernia. Right? This is clear?
Yes.
This is what we have discussed already, and we have also talked how it moves with the lateral wall. Here it is showing the lateral wall on obturator fascia, right? Now, what are the branches it gives? Actually, it gives one branch. Look here. It is going to iliac fossa, iliac branch. This branch gives blood supply to the iliac bone, nutrient artery, and also blood supply to the iliacus muscle. And also it makes anastomosis with iliolumbar artery. Right? If you can remember it, that's great. If you don't remember, still no big deal. You always remember corona mortis. You always remember corona mortis can be made very dangerous when the anastomosis and its locations.
Yes.
And when why you can forget the
Iliac
iliac
branch.
branch of obturator artery. But if you are very, you can say, good doctor or super duper type of academics, then you might remember this. Then it has one branch which is going down, and this is going to the bladder. We call it vesical branch. Then it has one branch just before going leaving, it gives a branch to the pubic area, bone on the back. Right? This is pubic. So how many branches? Wow. Let me make a simple diagram. This happens to be your pelvis, right? You must have legs and something in between the legs. So what I was talking about, aorta was here. What was here? Common iliac,
Yes, sir.
right? Then common iliac, internal iliac, and it continues as external iliacs, and this will become here femoral arteries. It has become two laterally anyway. Femoral arteries, right? Here was external iliac, just this was internal iliac. It gives anterior division and posterior division. Anterior division and posterior division. From here, classical branch was coming. Classical origin, what was it?
Anterior branch of internal iliac.
Which will eventually come into thigh through the tunnel, right? Now, what is this? Normal or classical or regular origin or most common variant, right? Now, this has branches. Number one, it gives a branch to the iliac branch, which gives to the iliac fossa, goes to the iliac fossa, supply the iliac fossa bone, and also supplies the iliacus muscle and meets with iliolumbar artery. Then it has one branch going medially and inferiorly. This is going to the urinary bladder, so vesical branch. Then before it moves out into medial side of the thigh, it gives one branch which is going just behind the pubis, and this is called pubic branch, right? Let me show that pubic branch in this diagram. Yes. Okay, I can make it. I've made it here. What was this branch? Iliac branch. What was this branch? Vesical branch. What was this? Pubic branch. But here in this diagram, it is more beautifully made. Look at it here. What was this? Artery with normal origin. It is giving a pubic branch here. It is going on the back of the body of the pubic and upper ramus. Now this pubic branch, right, coming from the normal obturator artery, meets with the pubic branch of, what is this? Inferior epigastric. They shake hand there. This is very dangerous. Not in normal circumstances. Normally there is very low flow area, so it is not dangerous. But if this become a big artery, what is this? Pubic branch of artery, or this pubic branch of obturator artery. So either this connects down or this connects up. There is a big connection between external iliac system and internal iliac system, and this anastomosis here is converted into corona mortis. This is converted into corona mortis. Actually, here in the pubis, there is one artery, this one coming. What is it? Pubic branch of? One coming here, what is this? Pubic branch of? Obturator artery. One of it is going medially and meets from its counterpart. So, pubic branch of what is this? Obturator artery. As it goes upward, it crawls upward on the back of the pubis, right? There it will shake hand with what? Pubic branch of the inferior epigastric, and it will also give a twig which will go and shake hand with its counterpart on the contralateral side, right? This anastomosis is usually innocent, meek, humble, but if there is a big origin here, or this artery become very big, this anastomosis become high flow, high pressure system, corona mortis. Or if normal artery is not present, and from this a very big artery is going down, right, and also part of the anastomosis, and that big artery is aberrant obturator artery, dangerous corona mortis. And these are even though in this diagram we have shown arterial system, but this anastomosis can be venous anastomosis as well. Rather, most fortunate people don't have corona mortis. Less fortunate people have arterial corona mortis. Least fortunate people have venous corona mortis. And people who are really doomed, they have arterial and venous both corona mortis. And we don't know any one of us have it, because if you, statistically speaking, if you talk about the presence of corona mortis of arterial and venous combined, in some population they make more than 50% of the population, right? Let's come back. So now we have talked about intrapelvic branches, which was iliac branch, vesical branch, and pubic branch. Clear? Now from here, what was this? Obturator canal. It exits into medial wall. Now it is shown here. This has this artery, obturator artery, has exit and come out into medial part. Now we are looking from the front. We are looking at the, what is this bone? Hip bone from the front. And this is, what is this? Pubic bone. This is superior ramus, inferior ramus. This is obturator foramen, and this is ischium, and here is ilium. Now, this artery comes out. As soon as it comes out, it gives two branches. One goes anteriorly, another goes posteriorly. So we can say, as soon as it comes out, it has a relief. So it decides to wander about. So it says, some of us goes to the posteriorly, some of us go to the anteriorly, right? So this is anterior branch, here is posterior branch, and it's more beautifully shown in this diagram. What is this exiting here? Obturator artery. As soon as it exits into medial compartment of the thigh coming from obturator canal, as soon as it comes down, it bifurcates or splits or divides into anterior and posterior branch. Anterior branch, look here. Anterior branch moves forward and then downward. Posterior branch moves backward and also downward. And then both of them anastomose with each other. Right? This is one thing. Anterior branch goes anteriorly and downward and then backward. Posterior goes posteriorly and downward and anteriorly, and then they meet each other, smile at each other, and maybe kiss each other. And this is not kissing anastomosis. This is just anastomosis between anterior and posterior branch. And another thing, this branch, anterior branch, also makes an anastomosis with medial circumflex femoral artery. And posterior branch also makes, you can say, what is this? Anastomosis with inferior gluteal artery. Right? These are very important. So what I can say, anterior branch makes two anastomosis, one with the posterior branch, second with the medial circumflex femoral artery. And posterior branch makes anastomosis with the anterior branch and also with the inferior gluteal artery. Now, this anterior branch, it supplies blood to which structures? Actually, this anterior branch gives many branches which are considered muscular branches. They supply the muscles in the medial compartment of the thigh. Noteworthy muscles, I must say, anterior branch I'm talking about. Look here. Anterior branch, the muscle that is supplying obturator externus, because there is a muscle, as there was obturator internus to the inner side of the membrane, obturator membrane, there is also a muscle here, obturator externus, outside the membrane, and these arteries are buried between the membrane and obturator externus. From there they are giving muscular branches. Now, obturator externus, then pectineus, then they are giving gracilis for your graceful legs, gracilis, and then adductors, especially which adductor? Adductor, especially adductor longus and adductor brevis and maybe adductor magnus. So muscles on the medial side, right? Obturator externus, then other muscle which are notably pectineus, adductor longus, adductor brevis, adductor magnus, and here it is going gracilis, right? So we can say it is basically for the muscles, right? Now let's come to the posterior branch. Wow, posterior branch also gives muscular branches to those muscles which take origin from the ischial tuberosity. Now where is ischial tuberosity? Okay, it is behind it here, this area. You see, this is posterior branch. It is giving branches to the muscles which originate from the ischial tuberosities, right? But if you want, you can forget this muscle. There is one tiny branch with mighty function. Tiny branch with mighty function in the children, you should not forget. There is a very super special branch coming from posterior branch of the obturator artery, and this is which goes deeper, moves towards the hip joint. It goes through the acetabular notch under the acetabular transverse ligament, and then it goes into acetabular fossa. It supplies there. Some branches ramify in the fat pad present over there, but a very special, super special branch, right, is coming from here, and it enters into ligamentum teres or ligament of head of the femur, and it goes and supplies the head of the femur, right? This branch is called acetabular artery, acetabular branch. This acetabular branch is extremely important. Why it is extremely important? I will tell you. Acetabular branch is extremely important. First, try to understand it is coming from obturator artery. Which part of the obturator artery? Extrapelvic part of obturator artery. Which part of the extrapelvic obturator artery? Posterior branch of the extrapelvic obturator artery. From there, this tiny branch with mighty function, because it is going to supply head of the femur, and it's a very important supply, especially in children. So this is acetabular branch passes in between the inside the, what is this, acetabular notch, under the acetabular transverse ligament, come to acetabular fossa. It gives some branches to fat pad here, and a very important branch which is called foveal branch. Foveal branch which enters into ligamentum teres and comes to the foveal capitis, a part of femur, and there it gives branches. Now this is very important to understand. In children, right, this part of the bone is growing, growth plate, epiphyseal. This is growth plate. So no blood supply can come from down to up. So in children, the main supply of the head of the femur is this foveal branch, which is itself a branch of acetabular artery, which is itself a branch of posterior division of obturator, right? Now in children, because head of the femur cannot get blood supply from any other source, the other sources should be coming from down to up. I will show you. For example, this is medial circumflex artery, this is lateral circumflex artery. Both of them are making a anastomotic ring around the neck of the femur, lower part. From there branches goes, and these branches which are going upward, and these are called retinacular branches. These retinacular branches are most abundantly given by the medial circumflex artery, right? These retinacular branches, I should write it here. Retinacular branches. These are extremely important for when children are more than 15 years, because what happens that around 15 years this growth plate closes, epiphyseal plate closes and allows the arteries to go up. So these reticular branches which are coming from mainly from the medial circumflex femoral artery, they become the main supply to the femoral head, and gradually it dwindles off. It gradually become less flow artery. So what happens in children, as growth plate is not allowing any artery to reach head of the femur, so head of the femur mainly depends on foveal artery, which is itself a branch of acetabular artery of the obturator artery, posterior median, extrapelvically, right? Now, as children grow up to the 7 years of age, the real and main branches, foveal. But after that, up to the age of 15, foveal branch in most people has become very low. What is this? Very low flow, right? And it has got other sources like retinocular artery, right? Now, imagine a child, 4-year-old child, 3-year-old child. If, for example, hip joint is dislocated, right? Or due to any reason, I will not go into reasons, but due to any reason, this foveal supply or acetabular supply to the head of the femur in children, if that is disrupted, what will happen? If this artery is disrupted before the other supplies are there, right? Then what happens? They develop severe ischemia to the head of the femur, and gradually head of the femur undergoes necrosis. We call it avascular necrosis. This condition is also called Legg-Calvé-Perthes disease, right? We will discuss it later. But what I wanted to say, that Perthes disease is a condition in which children, head of the femur, undergoes avascular necrosis when ligamentum teres having the foveal artery is disrupted, or acetabular artery which gives a branch, foveal artery, is disrupted, and severe ischemia occurs to the head of the femur and resulting into avascular necrosis, right? One more thing before I leave. Now, this is the end of the anterior branch and posterior branch, right? Anterior branch giving mostly muscular branches and posterior branch giving muscular branches, right? But very special acetabular branch, and which gives foveal branch, and if this branch is damaged in the children, there's a tragedy, avascular necrosis, which is also called Perthes disease, or very long name because there were 3 different doctors in 3 different countries, right? They described the same condition independently. So we have such a long name, but I would call just Perthes disease, right? Now, one more thing. You know, if you have abdominal hernia or groin hernia, usually you find a bulge there, abnormal bulge. But there is one hernia in this area which does not produce any bulge. Which does not produce any bulge, but produces severe pain on the medial side of the thigh, right? It can, and also patient will have, because loop of bowel or piece of bowel is in that herniating position. So there may be a patient who comes to you who has bowel obstruction, but you don't find any inguinal hernia, direct or indirect, no bulge of indirect inguinal hernia, no bulge of direct inguinal hernia, no bulge of femoral hernia, but there is bowel obstruction. With that, you are having pain where? Medial side of the thigh. What is it? You need to be student of Sherlock Holmes to find this diagnosis. This hernia is that Yes, come here. A piece of bowel or loop of bowel is herniating through the obturator canal. And as obturator canal is very narrow, if something extra try to go there, it compresses the nerve and artery and vein. So medial side of the thigh will have pain and severe ischemia. So listen today. It's a rare condition, but maybe one of you becomes Sherlock Holmes doctor. Right? One day you might be successful in diagnosing a rare condition which other doctors are unable to find. They will find but don't know what to do because they don't know what it is. So might be a person who has abdominal, what is this? Gastrointestinal obstruction, and with that he is having medial side of the leg, what? Pain or tingling sensation. Probably, most probably, he or she is having obturator hernia. What is that? Obturator hernia. In this obturator hernia, this feature, pain and tingling on the medial side of the leg, is given a special name. This sign is called Hauschip-Romberg sign. How? Hauschip-Romberg sign. How is it? How it? You got it. You got it through herniation through obturator canal. Right? Now I will very rapidly and briefly recap it. Right? Now, obturator artery, its origin is very important. In 70 to 80% people, its origin is from anterior division of internal iliac artery, and 20 to 30% its origin is external iliac artery branch, anterior inferior epigastric artery. Right? Number one. Number two. First, normally obturator artery, after its origin, it moves on lateral pelvic wall on the obturator fascia with two beautiful ladies, lizards. As a lizard, it hugs the lateral wall of the pelvis and moving downward and forward. Then there's upper lizard, what is it? Nerve. And lower lizard, obturator vein. Obturator nerve, obturator artery, obturator vein. They are moving on obturator fascia, right? Forward and downward and reaching to obturator canal. And while they are moving like this, ureter crosses medially, ductus deferens crosses or round ligament, and also ovaries medially in female. Remember, male don't have ovaries, right? Okay. Then, most medially, it is lined by it is having extraperitoneal fat and then parietal peritoneum, right? Here it gives iliac branch, it gives vesicular branch, and it gives pubic branch. Pubic branch is very important because it is going upward and it anastomoses with the pubic branch of inferior epigastric artery and also anastomoses with the pubic branch of contralateral side, right? This little anastomosis here is usually very innocent. But if this anastomosis become high flow, high pressure system, which is anastomotic system behind and above the superior ramus, with the pectineal ligament or lacunar ligament or femoral canal, we call it corona mortis, which may be arterial, which might be venous, or maybe both. How this anastomosis becomes high pressure, high flow system and dangerous anastomosis when there are two conditions. One condition is that normal obturator artery is there, but with the normal obturator artery, another obturator artery extra is coming. And this goes through the anastomosis and make it high pressure, high volume. This is accessory. What is this?
Accessory.
Obturator artery. Or normal origin is totally absent. And the only single obturator artery takes origin from inferior epigastric artery, and it is going through that anastomotic area and make it very high pressure area, right? And this artery will be called aberrant obturator artery. Now, this obturator artery, when it reaches anteriorly and forward, eventually what was the fascia under it? It was gliding over obturator fascia. Obturator fascia start wrinkling, folding, and makes a groove and eventually canal, right? And then it goes through obturator foramen, right? Where a part of foramen is bony and part of it is fibrous. Once obturator artery exits from there, it comes out and divides into anterior branch and posterior branch. Anterior branch supplies muscles on this side. Obturator externus, pecten pubis, gracilis, and adductor longus, brevis, and magnus. The posterior branch goes backward and supplies the muscles attached to the ischial tuberosity. But posterior branch should be remembered and engraved on your cerebral cortex that it has a very tiny but branch with mighty functions. And that tiny branch is acetabular branch. Acetabular branch here, and this acetabular branch will go to the acetabulum and give branches to the fat, and also give a foveal branch will go through ligamentum teres or ligament of the head of the femur to supply the head of the femur. This is a very high flow branch in children, right? But as we grow up, as children grow up and growth plate matures, and it allows the other arteries, retinacular arteries, which we will discuss later in the which are derived from the medial circumflex femoral artery, right? Retinacular artery, if they approach, what is this? Head of the femur, then this artery, what is this? Foveal artery, its supply becomes gradually less and it atrophies, right? But now, two things. 3 clinical conditions with this obturator artery and 2 variants. Variants: accessory, additional to the normal. Aberrant, no normal, only abnormal. Then clinical condition is corona mortis, very severe hemorrhage. And here I want to tell you there is another nearby area which is the risk of hemorrhage. Number 1, corona mortis. Corona mortis is anastomosis, right? What is this branch? Here is inferior epigastric artery and another artery is coming down. This is accessory artery. And this is, in this area, corona mortis, right? If you disturb it, as I told you, there can be severe hemorrhage. But I want to tell you another nearby area which is also dangerous. Look at a special area, triangular area. This is ductus deferens in male. Female, it will be round ligament of uterus. And here are gonadal vessels. Here are gonadal vessels. And what is this? This is folded. What is this? Fascia. Which fascia? Parietal pelvic fascia. So, ductus deferens medially, these are gonadal laterally, and here peritoneal fold, right? This triangle, this is called triangle of doom. Triangle of doom. Wow, if you do some mistake here, again your patient is going to die. You know why? In triangle of doom, here lies the iliac vein and iliac arteries. And while operating in this area, if you injure these vessels, the very high flow vessels, or high pressure vessels, and massive hemorrhage will occur and death can occur if you don't manage it very rapidly and sharply. Right? So now you have any question? No question? Okay, best of luck. We'll have the next lecture will be coming on blood supply of the head of the femur. Right? I told you there are 3 clinical conditions very important here. One was corona mortis and hemorrhage. Number 2, no, obturator hernia, right, which is with the Hauschip Romberg sign, pain here with obstructed gut. And number 3, Perthes disease, avascular necrosis of femoral head of a baby, a pediatric problem. Okay, thank you very much. Best of luck.